Hello everyone. So today we are going to learn about the pathogenesis of the preeclampsia. So normally in preeclampsia we have three main features. One is hypertension, proteinuria and edema. So now we'll see how hypertension will occur. So normally the basic pathology is endothelial dysfunction and the vasospasms. Okay. Now this too will occur because of the abnormal placentation. So now we'll see what is the normal activity that is occurring during pregnancy. Now first thing is trophoblastic invasion and uterine vascular changes. So normally in the uteroplacental bed there are spiral arteries present. So the trophoblasts invade into the walls of the spiral arteries. So this will occur in the first trimester and the second trimester. But in the first trimester the trophoblasts invade up to the decidual segments, okay, and in the second trimester another wave of trophoblasts invade, but this will invade up to the myometrial segments. So now what this process will do is, what will happen by occurring this means, this process will replace endothelial lining, okay, and muscular arterial wall by fibrinoid formation. So because of this trophoblastic invasion, the endothelial lining and the muscular arteries are replaced by fibrinoid formation. This will make the spiral arterioles to become distended, tortuous and funnel shaped. Okay, this will make the spiral arterioles to become distended, tortuous and funnel shaped. Because of this change, they will transform the spiral arterioles into a low resistant, low pressure, high flow system. So because of this trophoblastic invasion, the spiral arterioles form into low resistant, low pressure and high flow system. So normally this is the normal. So in preeclampsia, failure of second wave of trophoblastic invasion occurs. So failure of second wave of trophoblastic invasion occur, and this will cause reduction of blood supply to the fetoplacental unit. So this is the main thing. Second wave trophoblastic invasion will not occur. This will decrease the blood supply to the fetoplacental unit. Now in the normal pregnancy, angiotensin 2 is destroyed by angiotensinase enzyme that is released from the placenta, and in the vascular system becomes refractory to the pressure agents, and vasodilators like nitric oxide and prostacyclins are produced. Now these two systems are in balance, okay. These two systems stabilize the blood pressure in the normal pregnancy. And VAGF, vascular endothelial growth factors, it increases and restores the uteroplacental blood flow to the normal level. So these are the normal things. One is angiotensin 2 destroyed by angiotensinase that occurs from the placenta, and there is vasodilators are released like nitric oxide, and these two are in the balanced system, okay. And another one is VAGF, vascular endothelial growth factors, that will increase and restore the uteroplacental blood flow to the normal level. Now what will occur in preeclampsia is, in preeclampsia, imbalance in different components of prostaglandins will occur. This will increase the synthesis of thromboxane A2. What is this thromboxane A2? This thromboxane A2, it is an potent vasoconstrictor in the platelets, okay. Another way of occurring hypertension is increased vascular sensitivity to the pressor angiotensin 2. Now as angiotensin 2 increases, it will also cause vasoconstriction, which causes hypertension. Now there is a decreased production of nitric oxide. Nitric oxide causes vasodilation. It will cause relaxation of smooth muscles, and it will inhibit the platelet aggregation and prevent the thrombosis. Now decreased production of NO occurs. So this causes vasoconstriction. Another one is synthesis of endothelin 2. Endothelin 2, it is a potent vasoconstrictor. Another one is, because of the injuries, inflammatory mediators are released. Because of these inflammatory mediators, leukocytes cause endothelial injury, okay. Now this inflammatory mediators will cause the injury, and this will lead to abnormal lipid metabolism. This will increase the amount of oxidative stress, reactive oxygen species, lipid peroxidase and superoxide radicals, and which will cause the endothelial injury and the dysfunction, okay. Now another one is vascular, that is due to poor cytotrophoblastic invasion. Now cytotrophoblastic invasion will make the spiral arteries low resistant, high blood flow. Now poor trophoblastic invasion means they will become high resistant only, because poor trophoblastic invasion. So because of this, hypoxia of placenta will occur. This hypoxia will activate the apoptotic pathways. Now, because of this apoptotic pathways, placental growth apoptotic pathways, that's it. Now, placental growth factor. Placental growth factor, these are angiogenic protein secreted by the syncytiotrophoblasts. Now, this will promote the placental angiogenesis. But this SFIT1, that is soluble FMS like tyrosine kinase 1, it is an anti-angiogenic protein. It will adhere to the this VEGF receptors and placental growth factor receptors, and they will prevent the angiogenesis. Now, imbalance in angiogenic and anti-angiogenic factors. Another one is mutation. So these are all the causes of hypertension. The main things is like decreased NO, means all the vasoconstricting activities are increased. Thromboxane A2 is increased, and decreased cytotrophoblastic invasion is occurring, and synthesis of endothelin 1, which is an potent vasoconstrictor. These all are increased, and imbalance between the angiogenic and anti-angiogenic proteins. So because of all this, there is a vasoconstriction that causes hypertension. Now, how will edema occur? Edema, the cause is not clear, but theories that tell are there is, because of that increased oxidative stress, there is endothelial injury. Because of this endothelial injury, increased capillary permeability will occur, and this will decrease the pressure, and this will cause fluid retention. Now, proteinuria. Proteinuria will occur because of the same spasm of the afferent glomerular arterioles. Because of this spasms, there is decreased blood supply. So, anoxic change to the endothelium of the glomerular tuft, which cause glomerular endotheliosis, increased capillary permeability, and increased protein excretion. Capillary permeability is increased, means proteins are lost into the urine, absorption is decreased. So because of that, proteinuria is seen. So this is the mechanism of action of preeclampsia. I hope you guys understood it. Please subscribe.